Okay, folks, if I can ask you to please take your seats. We're determined to be on time here and precise and make sure we get all of these issues aired and get everybody out of here on time. So thanks. That's very responsive. Thank you. That's terrific. Okay, so panel 2 is the question of the case for and against reputation. We've heard a little bit about reputation already. It is a key element of the rankings. As Avery explained, in the early days, it was the only ranking. It was all it was a survey of practitioners. And as time has gone on, and as more and better data has become available, it has diminished in significance, but is still significant. It's slightly under a third now. We want to air out. We'll get an opportunity to talk a little bit more about what exactly is in it, what it means. But I think we really want to address the question front and center here, both the value of it and what the capabilities of the people doing the evaluation are. So we've got a couple of new panelists who have joined us. Quick introduction from the left. We know Brad Narr from Mayo, Tim Gardner coming back, Vinita Bahl, Director of Clinical Information, University of Michigan, Sharon O'Keefe, President, University of Chicago Medical Center. Brent's been with us, and Peter Slavin, President of Mass General Hospital. And it would be remiss if I didn't make as an offhand comment the fact that Mass General is now #1 on the U.S. News rankings. Not that that matters at all, but Johns Hopkins had been #1 for a number of years, and Mass General, because the numbers are what they are, supplanted them. I happened to have been in Boston in the summer doing another panel discussion regarding urban affairs, and I was interviewing Tom Menino, who is the mayor of Boston. If anyone knows Mayor Menino, he's sort of the new Mayor Daley. He's been in office now for 26 years and a terrific politician, very successful in Boston, and had a great sense of pride that Mass General had become #1, to the extent that he had a parade that was similar to what they did when the Patriots won the Super Bowl. And being the politician that he is, he put his arm around me and leaned into me in his ear, and he said, "I just want to tell you, I appreciate you putting your thumb on the scale for me." So I did not. Avery knows that. I couldn't if I wanted to, but it was, when we just a quick sense of perspective. #1, #2, #3, we realized these are all great hospitals, and sometimes the numbers are pretty fine. We rank numerically. We rank everything we do numerically because that's our philosophy. People can sort out the decimal points, but I know it can be important to move up a few places. So we always try to keep a sense of perspective on that. One of the factors making that happen, reputation. So let me start with Peter Slavin and give us your thoughts on this. Peter, is it worth it, besides this year?
Yeah, well, first of all, we've been very bullish about these rankings, particularly this year, so we're not really sure why there's all this debate about them. But more seriously, I give U.S. News and World Reports a lot of credit for developing a system which I think is as rational as any other, if not more so. I think we all recognize that measuring hospital quality is an imperfect science. As we've heard earlier, the measures that we have available to us are imperfect. That applies, I think, to the administrative data-derived measures, but I think it also applies to reputation as well. But I think to rely solely on administrative data would, I don't think, be doing a service to our consumers, to patients who are trying to make use of this information to make more informed healthcare decisions. Using administrative data in healthcare to make decisions about hospitals, to me, seems a little bit like trying to decide where you go to eat, what restaurant to go to based on an analysis of the checks that restaurants generate for their customers. And it seems like asking maybe other chefs where they would go or what restaurant they would recommend might be a reasonable thing to do in addition to looking at those checks. So reputation, as it relates to hospitals, also is an imperfect measure. I honestly don't know how imperfect it is, but to the extent that it's driven by history or driven by marketing efforts, that's not a good thing. But to the extent that it's driven by other physicians' knowledge of where the best physicians are located, what institutions do a good job in handling difficult referrals, what institutions are innovative and not just reading the textbooks but helping write them, I think there are potentially a lot of very important factors underlying reputation, and I think it might be worth U.S. News trying to better understand how physicians come up with their reputational rankings and maybe try to figure out ways to minimize the ones that aren't useful and maximize the ones that are.
Yeah, well, actually, Peter, you probably raised a question right off the bat that we ought to address, Avery, which is what exactly goes into that reputation survey. Let's get the facts on the table before we start talking about them.
16 specialties. We survey 200 board-certified specialists in each specialty, chosen randomly, adjusted for regional variations so that no part of the country is over or undersampled or over or underrepresented. We ask physicians to name 5 hospitals to which they would send patients in their specialty who need the care that represents care that's particularly challenging or need a procedure that's particularly difficult or in some other way poses a challenge. We get a response rate of approximately 50%, which, as anybody who does reputational surveys knows, is a very nice response rate. And we aggregate the numbers over 3 years. So it's a rolling 3-year figure, meaning that in any given year, what you see represents a survey of close to 10,000 specialists divided by specialty. One thing that I think is very important and almost always overlooked in analyzing the U.S. News rankings and the role of reputation is that remember that in any given specialty, we actually evaluate anywhere from roughly 500 hospitals that met the eligibility requirements to as many as, I think, 1,800 in some specialties. So what you see, if all you're looking at is the ranked hospitals, is the top 50 out of a set of 500, meaning it would represent 10%, to 1,500 or more, meaning it would represent even 3%. You're seeing the top thin layer. If you go down those rankings and you get to number 20 or 25, and so now we're talking about the top 1% or 1.5% of hospitals, you start seeing those reputational scores go down vanishingly to the point that there are many hospitals, ranked hospitals in the top 50 with 0 or negligible reputational scores. So the notion that reputation drives the rankings, I think, needs to be countered from the very beginning. It is the case that reputation is extremely important at the very top of the rankings. I would submit that per the comments of and opinions of my late colleague, Dr. Healy, and others have echoed, that there are hospitals that represent an elite that everybody recognizes, whether it's based on a perfect understanding or an imperfect misunderstanding, that these are extremely significant medical centers. So keep that in mind. If you look at the guide, if you pick that up on the way in, you look at those specialties, you will see that the vast majority of hospitals have reputational scores that are extremely low. And once you go online, drop below that top 50, you're going to see a preponderance of zeros. And to me, that cuts the legs out from under much of the argument that reputation is a sole determinant or an overwhelming determinant of the rankings.
Okay, well, that settles that. Thank you all for coming, and we'll have a safe home. One point for you, Peter, and then I want to go to our other new folks. Yeah.
I mean, clearly one thing that some patients are looking for when they choose a hospital, particularly when they're very sick, is they want to be in a place that is sort of advancing medicine, and that area is involved in clinical trials. And it seems to me that U.S. News could measure some things that try to get at that directly: NIH funding, clinical research funding, publication track record, et cetera. So there are some direct ways to try to measure that might help augment the reputational rankings.
Yeah, good. I want Vinita and Sharon both joining us new. Your thoughts on that, Vinita?
Sure, yeah.
Why don't we start here and we'll...
I take Dr. Cameral's point that reputation has become less of a factor in the overall ranking, especially this year. But it is still very important. And I speak as a representative from the University of Michigan, which is on the honor roll, but is not part of the top tier of hospitals that typically have very high reputation scores. So physicians in our hospital constantly ask the question, what does the reputation score mean, and how can we improve on it? And I think this is to Dr. Slavin's point. It would perhaps be better to try and disassemble the components that you're trying to get at with reputation and offer maybe some other metrics beside just the survey responses. But things that have arisen as questions about how to improve a reputation score are, do we hire star faculty? Do we advertise more? Do we focus on increasing referrals from a broader catchment area? Do we emphasize clinical and translational research? How do you improve the reputation score? Because I would suggest that those top tier hospitals are ones where everyone has commented that there's face validity in the rankings. And clearly the top tier hospitals have name recognition. And there is a perception on the part of not only patients but physicians that they are highly specialized, excellent academic medical centers. But that just gets reinforced year after year. So how does a hospital like ours break into that top upper echelon?
Yeah, Sharon?
Yeah. First, thank you for the opportunity to be here, and I will say that I believe U.S. News and World has had a 20-year track record of trying to improve itself year over year, and the rankings are getting better and the methodology is getting better. On the reputation issue, I think if you go back to what was talked about at the first panel, all of this is about getting the patients or consumers out there to eventually have the most robust information to make a decision that is going to be best for them for arguably complex, most challenging conditions that are out there. And the reputation survey does get you, I think, to a large extent, potentially to the right physician, because there's a kind of a linkage there in who's surveyed and what their view of their referral pattern is going to be, which is then expanded to that individual practices at that hospital. You're going to get some components in there then of the technologies and things that are made available. I was struck at the earlier panel that the reputation score became kind of a surrogate for the process component of the D.M.D kind of structure. And to what you were just mentioning, how to improve that could be to add more metrics. Would sound like they're in slim supply out there. The other question I think that we've had a chance to discuss back at the home front is, do you expand who is sampled? And people across the country who may have more expert eyes into processes or institutions that are most advanced in systems of care and innovation around those, or other constituencies beyond simply a sampling of physician. Could it be chief medical officers, chief safety officers, other professional disciplines who may have also a perspective on what's the best place to go when you're trying to make a choice.
Yeah, good. So we did do, actually, we will be publishing this with Mount Sinai after, we did do a survey in advance of this discussion of chief medical officers, asking some of these questions about about the validity of the rankings. And one of the questions was the role of reputation survey, and 86% of respondents felt that reputation should be factored into the rankings. 22% dismissed reputation as not at all important, but I think we saw that as yeah, I know. Who did this? less than 22%. It's not a math problem; it's a reading problem. So we're okay on that. But so I think this is a bit of a blunt instrument, but it was helpful in understanding, at least broadly, that there was wide acceptance of it. So, but I think some of those, maybe Avery, if you want to even address or thought about some of these broader survey notions, where expanding the sample size.
Ben has those. I think he might be able. I don't have the survey in front of me.
Right. No. I mean, in terms of would we consider? I know we have considered sending out a broader survey.
It's come up periodically in discussions with NORC and then after NORC with RTI to talk to CMOs and service chiefs and so on. Is this thing on? Supposedly it's not. And it's not clear it's not clear how much that would change anything. And if we substituted one by one, if we kept the survey size the same and then substituted people who were presumably more informed, it might or might not change anything. I just don't know. We can certainly look into it again. One thing, I need to add two things to my earlier explanation, though. One is that we also stipulated that when people surveyed provide nominations of hospitals, that they disregard cost and disregard geography. So the presumption built in is that they could and should think of simply the best place for or places for patients, as I've described before. The other point I want to make is that a few years ago, RTI expanded the survey to ask physicians some questions about the factors that they considered when making these recommendations. And we were very encouraged to find that where they went to medical school, where they did their residencies, where they pursued postdoctoral fellowships or had other sorts of personal professional relationships, none of these were major factors. They seemed to take what we wanted to find out seriously, assuming that they were telling us the truth. So that was very reassuring.
I want to ask Tim and Brad, a couple of our clinicians here, one of the things that this centers on, what do doctors really know about other doctors and other institutions? And do you think that, what are your responses to this?
I'll take a try at this. I'm always leery of people that come to me and ask me to tweak something. But in the overall hospital rankings, we know the 16 areas, with 0, 1, or 2 points are the summation that kind of puts it into it. And there are 4 specialties that are reputation only. So psychiatry and PM&R and ophthalmology and rheumatology. And it might be nice to put some of the quantitative factors that we have in the rest of the rankings into those to kind of begin to put a tiny bit more science into it. Now, we know that we can't approach what's going to happen in Mass General unless we do something about those reputation-only specialties, because we don't have an eye infirmary. We have a 7th floor of the Mayo building that's our eye group. And we don't have some of the different advantages when we're looking at a silo that has a national reputation. And the way they get that national reputation is what everybody in this room knows we do. We go to the meetings, we publish, we make breakthrough research discoveries, and all the different things that go into the science and art of medicine. So it's participation in these things and what you're actually doing as a specialty to have something to have a reputation about that's going to allow you to creep up in these areas. And we know we have a long way to go in ophthalmology. We have much less of a distance to go in physical medicine and maybe psychiatry. And rheumatology we're doing it. And so we had a very, very specific program with resources outside of the normal allocation budgets of the Mayo Clinic to look to see what we could do to help these reputation-only specialties improve their reputation. A tiny bit of it is the marketing piece. What do you do at your national meetings and things like that? A huge amount is participation in your specialty at the national level, so you have something to do there. So we're doing specific targeted recruiting, mostly on the research side. Some of this in psychiatry has to do with the clinical research side because we have some fortes there. Mood disorders, for instance, I don't know anything about mood disorders except for I'm sad all the time. These guys are really at the cutting edge in some of these various areas, and we want to allow them to have resources outside of the normal allocation, outside of the normal budgeting processes to try and put this forward, and then the pressure's on them over the next 5 years to see what they can do.
Okay. Yeah, Tim?
Well, I come from a slightly different perspective on this one because my current system is not a honor roll candidate for the foreseeable future, hopefully fairly soon, but not for the foreseeable future, although I came from many years at Hopkins and University of Pennsylvania that were in play there. But, I think I agree with the sense that has, I think, been expressed here that there is some face value for the reputational assessment. It is a sort of peer review, and the methodology is about as good as you can get if you're thinking of surveying physicians. I do think that there is oftentimes a little lag. I mean, I can think of a couple of very high reputational ranked institutions where, at least in programs that I'm quite familiar with, they've fallen off their game a bit, but there's a lag there. It probably doesn't make that much difference, but I think that is an issue, and I think that those on the inside may know that, and then there are these other sort of interesting things that I never thought about. But I think it has face validity. I would think that as you go forward, it may be possible to reduce the reputational score component a little bit and add some additional metrics that are now becoming available. But I just want to say one other thing interesting. This morning on MSNBC here in New York City, there was an ad by a quite southern medical center promoting their expertise in genetics and genomics. And I thought, it wasn't that interesting. Who are they advertising? What's the purpose of that particular national advertising campaign? I think clearly they're trying to, they hope to enhance their reputation by instructing people. So that's where the business side of the thing has come into play.
Yeah. Brent, your thoughts on this?
Just a few thoughts on it. The first is that if you come to the Board of Trustees level for almost any care delivery group, usually unpaid for most hospitals, for most care delivery systems, usually community leaders, reputation is really, really important. These guys tend to emphasize that quite highly. I think it has to do with their role within the board and how they interact with their peers. So there's no question that it's very, very important. Second thing, just to be a little provocative again, such evidence as we have shows that reputation, well, how to say it, your ability in research, publication, develop new technologies is not strongly associated with care delivery performance. Perhaps the best data comes out of the Pacific Business Group on Health. They were looking at Stanford University. Some areas Stanford was truly excellent. Others it was actually some of the worst in the state of California. And the funny thing is on average, they're about average. On average. So reputation is not strongly associated with care delivery performance. Part of the reason for that maybe is that you're looking at across the entire population they treat, not just the high-end special needs patients. That may be part of the reason for that, you see. We've got an interesting thing going here. The term for it is rescue care. A guy named Johnson in 1986 described that as the imperative that we feel to help people who are facing suffering or death. Later commentators pointed out that the things that we do don't have to work. It's the do something, she's dying phenomenon. And if you start to analyze U.S. healthcare in terms of rescue care, it explains an awful lot. We blow away the world on rescue care. But as soon as you say that you're looking for the difficult patients, the outliers, the unusual, you're saying rescue care, the most expensive care. The interesting fact, rescue care is not strongly associated with how long or how well people live. It's not associated with total health, particularly. It gets into the aspect of hope, almost, that we offer people hope, which people value quite highly. You hope for the miracle. But you may have to treat 100 or even 1,000 patients to get that one miracle. And in the patients where it doesn't work, you nearly always get a small loss. Well, some across 1,000 small losses for the one big win. And often it turns out to be slightly negative, believe it or not. This is one of the reasons why the U.S. system sometimes compares unfavorably to other nations. Just in passing, is our very heavy emphasis on rescue care. In passing, and I think there's a fundamental question that you have to think about or ask yourself in terms of what the intent of the rankings are relative to your heavy focus on rescue care. Let me explain what happens at a Stanford. The fact that performance doesn't tightly tie to research performance. I mean, care delivery performance does not. Who are you trying to inform? What are you trying to say? Are you targeting all Americans or just the subset who have very, very advanced disease when you release a report? That'd be the question back behind
So,
that.
okay, so we've got several hospitals here that are doing exactly some of that kind of care. Respond to that, Peter.
Yeah, no, I agree with Brent that this dimension of healthcare is extremely important, and I would argue that the institutions in the U.S. survey excel at it. We often refer to it as the shoestring catches, the very difficult cases that we occasionally make a dramatic difference in. I'll never forget a young woman transferred from another New England state to our hospital who was comatose. The other hospital was about to pull the plug on her. She was sent to Mass General, and our physicians going over with a fine-tooth comb found that she had this rare ovarian tumor, a teratoma, which has been occasionally associated with coma in young women. It was removed. She woke up. She walked out of the hospital. How do you measure that? That kind of care doesn't affect a lot of patients, but for the ones it does, it makes a world of difference, and I think it happens much more frequently in these institutions than others. So it's a very important dimension of care. When people are very sick, that's what some of them are looking for, and I wish we could come up with a way to measure that capability. I think it probably does co-vary with research activity and the kind of faculty that and staff that these institutions attract, but to measure it is really hard.
Mm-hmm. Yeah, Sharon and Vinita, your thoughts on that?
Yeah, very similar to Peter. I think, we many of our institutions exist in terms of a steady stream of these referral patients coming in, transferred from other institutions, and meeting the needs of oftentimes the clinicians to use and study advanced technology. So it is tied to, I think, the research interest, and hopefully to demonstrate the efficacy and the effectiveness of new technologies that are out there. So it's a very difficult, I think, balancing act in terms of how do you make the right choices in terms of when to either accept a patient because you believe you have something extraordinary to offer the care of that patient, versus kind of assessing that and saying you really don't. But a couple of other comments. I think one of the issues of the reputation halo is for the general population, it's focused on, I think, getting the most complex, challenging patients into the institution to apply the best science and technology and the minds of the clinicians. It does tend to also, for the general public, be interpreted and translate that you're also going to do incredibly well at secondary care or even primary care. And that is just a question. I'm not sure that necessarily translates immediately into other categories of patients when your systems are oftentimes designed around things that are extraordinary and, use Brent's term, rescue-oriented. And maybe that's a discussion where we're going to talk about in the third panel the marketing aspects of this, but it is definitely something that is out there that casts a larger shadow over secondary and seeking all services. And if you're good at the really hard things, you're going to be really good at everything else that you do. And I think that's a question as to whether there's a different way to assess that secondary or primary care. And last comment, kind of Brett's opening statement there about the interest from up to the board level. It is tremendous in terms of where hospitals stand on being an integrated system on both the university rankings, the school of medicine rankings, and the hospital rankings in terms of what I think is the increasing pressures for philanthropic base. And the reputation score, I think, is very, very important when you are out there from a fundraising standpoint.
Yeah. Vinita, your
Yeah, you make some excellent points, and this discussion has raised some questions in my mind about the maybe two directions that we're going in the discussion about reputation. We laud the reputation score for having some face validity, that it does in fact identify top-tier hospitals. At the same time, we say that it's encouraging that some hospitals with a 0 reputation score are still ranked. So it's a curious kind of view, two differing views. And I'd like to comment a little bit about why I think this situation exists. Because reputation still does have an extraordinarily high or significant weight on the overall ranking. But recent changes in the methodology from U.S. News and World Report has reduced its impact to the point that where in some cases for some hospitals the impact of the quantitative measures, the objective measures of mortality and patient safety and the structural indicators make a larger difference. I think it is important to comment on some of these changes because unlike in previous years, there is a much tighter distribution of hospitals in the top 50. And it doesn't take much to move from a ranking below the top 20 to within the top 10. And I think U.S. News and World Report potentially should consider the methodologic changes that they've applied to the reputation component as well as other components and what this all means to the overall methodology or overall approach to determining the hospital's final ranking. So I'll throw that out there just as a point that has certainly crossed my mind as I've reviewed these most recent rankings. And also speak to the point that was made about the perception on the part of consumers that these top-tier hospitals are not only excellent at providing care to the most complex patients, but for providing care to the, quote, average patient. And there have been studies that show that that really isn't the case. And they've been published, there have been numerous studies published comparing the U.S. News and World Report rankings to hospital rankings on things like the hospital compare measures. And I think this is an important topic to discuss. I think the fact that U.S. News and World Report can establish its rankings and the Joint Commission its own rankings, and for the two to look very different, confuses people. And I think it's, we on this panel and all of you in the audience understand that the U.S. News and World Report is really focusing on those hospitals that care for the most complex patients, which of those hospitals are best at caring for complex patients. But in this scheme, should we be also considering how these hospitals, academic medical centers mostly, are caring for the average patient?
So we have a simple solution to that complication problem. We're just going to eliminate everybody else, but that's... Can you let off with that slide about the Joint Commission? Do you want to address Vinita's point on that? I mean, is that a real problem, the disparities there?
I think it points to the confusion that the consumer faces, and that's related to everybody using a different database. I don't know whether the answer to that is to bring all you people together and try to get some kind of consensus around what's really valid data. I think it's a real problem. But while I have the floor, let me make a comment about reputational score. When I look at some of the reputational rankings, I am surprised by some of the outcomes. And Peter made the point earlier about how historical value seems to continue to permeate current ratings. So the real question for me is, how does a reputational score really reflect a place's reputation today and what they're really doing? And I would propose, provocatively, I haven't thought this through adequately, but just for people to think about, that perhaps randomly selecting 200 board-certified people doesn't necessarily give you the best universe of people to rate reputation. I know, for instance, in my field, that 200 board-certified psychiatrists may differ enormously on their knowledge of what is really the best programs around the country. Those who come from still from an analytic school may have no idea where the best treatment-resistant depression program is going on. So I might suggest that the U.S. News survey could consider, for instance, oversampling people who are board certified and members of the IOM, or people who are board certified and have already won the highest honorary awards from those societies whose membership is relatively selective in their disciplines, so that at least we can begin to get the true leaders of the field making assessments about what are the best places.
So I'm a little like a trial lawyer here. You opened up the notion of the Joint Commission, so I feel like I can start a new line of questioning. And so let's turn this on the Joint Commission for a minute here. What do people think about that ranking? Brent, you go.
So having spent some time with Mark Chasson, Truth in Advertising, an old friend, that's a very specific targeted program called Advanced Certification. They target kind of mid-level hospitals. They go in on a condition-specific basis. They develop a set of measures. I think of it as hospitals who are at a size where they have no alternatives. It's usually backed up with some fair application of Joint Commission resources, and it's performance measures on those very specific things as part of a structured program. So of course, they're looking at a completely different group of hospitals. I'm a little surprised that Duke's in it. That's my only real surprise in seeing it. I'm thinking, what in the world is Duke doing there? They usually don't play in this arena, if you see what I mean. So for its purpose, I think it's a very effective program. It's just that when you come up a layer, you don't see the differences within it. It's been very effective for Mark, too, by the way. Very effective, but he's really targeting those smaller community-level hospitals. And that's all the people you see within it, sure enough.
Other thoughts on Joint Commission?
I mean, I
Peter?
think measuring hospital quality is like trying to understand an elephant, and these different systems measure different parts of the elephant. And as I said, I think the U.S. News approach probably is the most comprehensive measurement of the elephant. The approach the Joint Commission takes is much more focused.
Go ahead, yeah,
Well,
Tim. Just Tim, one quick before you go. We're going to start asking for some questions too, so please be thinking of some things, and feel free to line up as we're talking here. But we definitely want to get to some other voices in the audience. Please, yeah, go ahead, Tim.
So this gets us a little bit into the business of ranking agencies and businesses and so on. But I think the Joint Commission has certainly had a beneficial role in hospital operations for a number of medical centers. I think they overemphasize their rankings because I think it's fairly narrow, and as has been demonstrated. But we're stuck with a plethora of ranking agencies, and if your hospital doesn't do well on U.S. News and World Report, and you look better on Hospital Compare or Health Grades or whatever, that seems to be a compensatory mechanism. But the overall ranking industry and the processes I think, have been beneficial. And we've talked about iterative adjustments and refinements that U.S. News and World Report can make to improve its assessment. We certainly, as a group, should be talking through American Hospital Association to HHS and so on. I think we're on the right path.
Questions? Great. Oh, terrific. Let's start. Yes, sir.
Bob Dittis from Vanderbilt. If you send out a survey and ask people to rank the top 5, you'll end up with obviously a few getting most all the votes, which is, I think, what's borne out. and when you look at who has all those votes, and then the reputation score is meaningless for all the rest of the hospitals because of no one gets a vote in the top 5, even though they might be top 10 or top 15 or top 20. So I appreciate respondent burden, but I think if you really believe reputation is important, and that's open to debate, although there's certainly been support for it, the methodology of having people just rank 5, I think, skews its value only into the very top handful of hospitals and doesn't distinguish anyone else. So maybe that needs to be reconsidered.
That's a good point. There are some methodological aspects to that. Obviously we're not looking for only 5 because we get multiple respondents in those 5. But it's a question. Where did Avery go? Ben, help. Anybody? Murray, help me out on that. I don't know. It's the question of why only ask for 5, and does that skew this in some significant way? Yeah, or a self-reinforcing halo.
There he is.
I did just want to mention that I think it was.
Yeah.
Oh, sorry, Emily Geisen at RTI. Just to that point, I wanted to mention that I think it was last year or the year before we did increase it to 10 nominations to see what kind of impact that had. And what we found was that on average, people still only nominated about 6 or 7 hospitals. So we thought it might be beneficial, and now that Avery's back, I can hand it over to him to talk about it a little bit more. But the other kind of negative impact was that it hurt the response rates. So I don't know if it was just a little bit harder question to think about 10 hospitals compared to 5. But ultimately, it had kind of a negative impact because we had fewer physicians responding than when we asked for 5 hospitals.
Good. No, Avery had his turn. He's not going to talk about it. We'll deal with that later. We've got too many questions lined up, and I want to make sure we get. Yes, sir.
I'm Bruce Gans. I'm the Chief Medical Officer at the Kessler Institute for Rehab, and I wanted to go back to the casual discussion about the fact that we are only ranked on a reputational basis. There are no other quantitative measures in rehab hospitals or units, and happily, we're very highly ranked in that scale, but we don't feel comfortable with that because, especially in the world of rehab hospitals, there is a very large body of data commonly collected that represents outcome and process measures. And at least in the world of rehab, we would like to see greater emphasis placed on some of the objective as well as the subjective. We see clear evidence of the fact that you can teach to the test. Our ranking went up significantly and consistently as we put more resources into marketing and promotion and getting our people out there and having newsletters and doing the things that anybody would think of doing. And I can tell you it worked very effectively. I think it's well deserved, but I don't think it's necessarily the only way that a potential client should be given information that they could make judgments on. So I'd like to make that recommendation and ask the panel's opinion about that same notion.
Yeah, I've responded.
No, I would certainly support that suggestion, and I think I would encourage U.S. News in the specialties that are reputation only to try to find some other data to complement their reputation. I realize in some, like rheumatology, it's hard to do that. There may be others like rehab where it's somewhat easier, but I think to try to give more of a balanced scorecard in all of these specialties would be a helpful thing to do.
Mm-hmm. Okay. Any other thoughts, Sharon?
No, other than I think my impression is in the world of rehabilitation that there is actually a fair amount of metrics that are available that could be compared. So it would seem that maybe can't take on all 4 of those that are solely ranked by reputation, but rehabilitation is a place where I think patients do have a choice. They have put a lot of time and thought into where they might want to seek those services. So it would seem like maybe if there was an early adopter kind of out of those 4, that could be one where it could be more quantified going forward.
Good, thank you. Next, please.
Jasmine Moshipur, Medical Director at Queens Health Network and Dean for Affiliate of Mount Sinai. I think I'm only representative from the City Hospital of New York City, which have 11 acute care hospitals, which 2 of them located in the borough of Queens, with the total number of the 2 hospitals about 900. being a referral center, or as some of us call it, dumping center for most private hospitals in the borough when they have a complex medical problem, both medicine, surgery, and OB. That is our hospital as a receiving, that we do not have any right to refuse any of these patients. With a group of the patient that they have 4 or 5 or more complex medical problem, I would like to know that, and scoring above 95 in past 3 JACO, for whatever that counts, I would like to know that how U.S. News would rank and put those hospitals with complex medical problem in compared to other hospitals.
Well, that question has come up a number of times. Avery, I think we've talked about it a little bit, but why don't we discuss more thoroughly?
We do use risk-adjusted patient data, MedPAR data. We obviously do not go below age 65, MedPAR being MedPAR. It's based on administrative data. We all know the weaknesses of administrative data, but it is risk-adjusted. And as I said earlier, we also exclude transfers in, so no hospitals anymore will be penalized for taking somebody else's dumped or expeditiously transferred patients. Beyond that, I'm not sure what we can do. We've begun looking at present on admission, because that's now been integrated into the DRGs, but we're not ready yet, because we tend to be very conservative about changing the kind of data we use and how we do it. And the message I get from RTI is that the POA data is not quite ready for prime time.
Thank you.
Okay, thank you. Anybody thoughts on that, Peter? You have
I mean, I have no doubt, as has been said earlier, that some hospitals, because of the socioeconomic status of the patients they cared for, are disadvantaged in this and other methodologies. I mean, I guess the advantage of it, and Ken and I had a brief discussion about this during the break, is that it keeps the whole issue of disparities on the table. There are clearly segments of our society, perhaps related to medical care, perhaps not, that are having different outcomes, and we as a healthcare system, we as a society need to do something about this. And so to completely adjust for that fact, it seems to me takes that issue off the table, which we don't want to take off the table because it's critically important for us to remain focused on it and committed to trying to do something about it. So it is a real dilemma.
Other thoughts on that? We deal with this in a number of areas, particularly education, very similar, and we're very conscious of it. We do a lot of socioeconomic adjustments in our high school rankings and college rankings, but this is very helpful to us to hear this perspective, I think. Yes, ma'am.
Thanks. I'm Misty Hathaway with Mayo Clinic, and I have a couple questions for U.S. News and RTI relating to the methodology around assessing reputation. Have you ever considered a couple things? One is shifting away from your mail methodology, understanding that demographically in my household, for example, if you're under 30, you'd never even look at your paper mail. And I just wonder if we're skewing with a paper methodology toward an older respondent. Have you looked at an electronic? And I'm glad to hear you say 50% response rates, but actually we've seen kind of increasingly lower response rates from the specialists. So I wonder if you've looked at an electronic methodology for gathering feedback. The other is just the survey question. There was a conversation about it's focusing on complex care, but have you thought about adding, consider things such as contributions to your field or innovations, recognizing that it's not just how you care for complex patients. So have you considered changing the phrasing of the question as well? So 2 questions about how you're gathering the information about reputation.
Next year's survey is going to be sent out on Twitter. We think 146 characters is sufficient to deal with these questions, but
yeah, that's right. Let's see how people respond to solicitations for spontaneous nominations. RTI and NORC before them have tried a number of approaches to the survey over the years, including web and email. This year, we did a web experiment this year, didn't we? Or was it last? We're going to this year. When we've sort of dipped our toe into into online responses, the results have not been improved, as I recall, beyond hard mail responses. And if we actually survey physicians online in some way, you talk about people younger than 30 not looking at their snail mail. I'm not sure how many patients look at their email, especially if they see usnews.com or even rti.org at the end of it. But we would also be making a serious negative impact on their income, because when we send out the survey, we include a $2 bill that is presumably a major incentive for them to respond. I'm sorry. The second question. Oh, right. Non-complex care. We'll do. Oh, right. Innovations. Here's where I have to join Brent James in being provocative. I suppose where I stand on these rankings, don't care from the patient's perspective about how innovative a hospital is, unless it affects my care. If there's some relationship between specific innovations and the quality of my care, then yes, I'd be interested in seeing those factored in. But to recognize that a hospital is being far-seeing, that it's putting itself on the frontier of research in some way, that's not bench to bedside enough for us to want to actually factor that in. I don't think. When it comes to children's hospitals, it's a little different. We look at research fellowships, and we look at other components that are related to involvement, but that's direct involvement that we think, especially in advanced pediatric care, can make a difference. But whether a hospital invests in a particular technology that right now is just out there and unproven, I don't see a good reason to do that.
The technology area is a really interesting one to us, and innovation. And I think one of the things that's clear is here, we don't want to create disincentives. But it may not be that it's something that fits in the ranking formula initially. We have tried to take account of this. We've looked at most connected hospitals, things that had to do with electronic patient records and things like that. So we want to be highlighting some of those sorts of things and doing some things that may have not matured to the point where they fit in the rankings, but so we'll be doing some of that going forward in the future. One more question here, and then we're going to take a break. Yeah.
Yep. Deborah Italiano from Stanford. We've been fortunate enough to be ranked in the specialties. We've had 2 years where we've dropped off the honor roll, so you can imagine there's a bit of consternation and a SWAT team approach. We fully appreciate the opportunity with U.S. News to help consumers make judgments, but we also really appreciate the opportunity to have a hospital make serious improvements by really understanding the numbers. And part of our consternation is we can't understand part of the numbers, and that being reputation, which does account for so much. I'll echo, the one big echo is trying to move it from a very subjective one question measurement to something with hard data. And I think this group here, we've heard a few ideas already. The brain power in this room to think of the hard measures to add to this would be phenomenal. The other, until we have that hard data, I'd really suggest that we do reduce the 32.5%, because it does. The problem with smaller hospitals, and we aren't one of them, but it makes that 0%. So it doesn't give them an opportunity to have that, and it does keep the club of 5 in the club of 5, and the other ones in the cusp that can be on, can't be on, not necessarily understanding. There was a suggestion of increasing the sample size. That again would help us as a hospital to understand the difference from year to year. Are we going in the right direction? Rolling through years, the chance to make an impact and understand what we did this year, good or bad, is really hard to do. You can't do it. And two other things I think in ways that you could help us is give us the, with so many methodology changes from year to year, if you could provide us the data of how did we do without the most recent methodology changes. So we could measure apples to apples, or the raw data, something that we could really dive into and really get meaty outcomes.
Great, thank you very much. Panelists, quick final word for anybody, summing this up with great questions and great dialogue, and wonderful things. But if anybody has a last thought.
You know, just one thought. I'm
All
not sure
right.
this should be the last thought, though. Just an idea that popped up, frankly. We have a national award for quality called the Baldrige Award. It has a fundamentally different focus than the one we've described here. Rather than thinking of quality in terms of reputation, you think of it as a core business strategy. With the business strategy, it focuses around key clinical processes. When we analyzed key clinical processes within Intermountain, we started with over 1,440 major conditions that we treat, 104 of them. 7% of them accounted for about 95% of all the care we deliver. You're struck by how common the common is. 95% of our care. Where our performance really does make a difference in people's lives. And you start to pursue it as a business strategy. You start to organize around those processes. You start to build data systems around them. You start to directly measure your own performance, bring the traditional tools of research into that side of the business, if you will. Should that be the focus? Do people have that infrastructure? Are people changing their performance for the vast majority of patients who seek their help? See, that would be, I think, a question that's worthy of consideration. A different kind of a reputation, I guess.
Thank you. We're going to take a 10-minute break. I want to thank our panelists for some great insights. Thank you.
I think that should be one factor.